Hi, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha and I am a nurse here at UWorld. We're so excited to see you guys back today. Today we're going to be diving into a really prevalent topic. It's chronic kidney disease. So kidney issues, if you plan to work in a clinical inpatient setting in a hospital, they're so prevalent in the hospital. You will definitely be seeing them. But if you don't plan to work inpatient, anyone who plans to take that NCLEX will definitely be tested on renal, genitourinary, all of those good things. Those systems will be on your NCLEX. So I think this is really pertinent information for you guys to pay attention to. Alrighty, so let's go ahead and let us know in the comments if you plan to test soon, or for anyone that has already tested, let us know what your plan is so we can either wish you good luck or give you a congratulations on passing. It's always so interesting to see where everyone is in their NCLEX study journey, where everyone is in their nursing school journey. So drop it in the chat. Let's see, I see Sharon's already taken it and a couple of people, so thank you so much for letting us know. To note, as always, we have our nurse chat moderators. We have both Nurse Jackie and Professor Brittany moderating for us. So stop in, say hi. As always, drop your answers in the chat. Let us know what you're thinking. And if you have any questions or comments as today's lecture goes on, make sure you let us know in the comments below. We want to hear from you guys. Alrighty, and so just a little reminder, this live will live on demand on both Facebook and YouTube. So if you ever feel like you want to drop back in, check it out, use it as a study reference for your future studies, you can always do that on Facebook and YouTube. Or if you just think I'm talking too fast and you want to slow it down, you can also do that. Alrighty, so let's dive into our lecture content, and I'm going to warm up the chat today with a question. So let's start out with a question. I'll get you guys ready to go. So we're talking about chronic kidney disease. Before we get into that, let's talk about what the function of the kidney is. So I'm going to challenge you all. What are some functions of the kidneys? I'm going to give you a hint. We're going to separate it into three main functions. We can separate it into three main categories. So again, go ahead and drop in the chat what the three main functions of the kidneys are. Let us know. I'm going to give you some time to do that. And in the meantime, a reminder, we go live 3 times a week, Tuesday, Wednesday, and Thursday. Tuesday is lecture-based, and then Wednesday and Thursday are our question drills. So make sure you join us again tomorrow and Thursday at 3 p.m. Central Standard Time. Alright, I'm going to check the chat. Alrighty, so I see a lot of filter, I see excrete, I see more eliminate waste. Way to go, guys. Per usual, you guys are absolutely on top of it. The three main functions of the kidneys are going to be to excrete, to filter, and to produce. So let's dive into that. What are we excreting? The kidneys are excreting the body's toxins. To filter, what are the kidneys filtering? So the kidneys decide, hey, what should we hang on to? What should we get rid of? And these elements that they're filtering include electrolytes, fluid, waste products, all of that good stuff. And lastly, to produce, this is something that is kind of a little known. I feel like it's something people don't always associate with the kidneys, but the kidneys produce a very important hormone called erythropoietin. This is both produced and emitted by the kidneys, and it plays a big role in the body as a whole. What it does is it signals the bone marrow to release blood cells when the red blood cell count is running low. So a great way to remember this is by linking the hormone and the name of it to what it does and what it's related to. So erythropoietin, kind of a mouthful, but it's easier to remember when you remember that the medical name for a red blood cell is an erythrocyte. So erythrocyte, erythropoietin, those kind of go hand in hand, and it makes it a little bit easier to remember. Alrighty, so now that we know what the kidneys do, what their function in a healthy kidney is going to be like, what do we see in chronic kidney disease? What's going wrong here? So chronic kidney disease is the slow onset disease. You may hear this referred to as an insidious disease. It just means it's something that takes a very long time to progress. This disease can take years to progress to end stage in what we call end stage kidney disease, or ESKD, or you may hear it referred to as end stage renal disease, or ESRD as well. It's important to remember that the damage that's done in chronic kidney disease is irreversible, meaning we can't go back and undo this damage. There is nothing we can do once the damage is done. So let's classify this disease. How do we stage this? There are 5 different stages of chronic kidney disease, and the good news is pretty easy to remember. It's just stage 1, stage 2, 3, 4, and 5. So no fancy names to remember there. And we classify these different stages, stages 1 to 5, using something called glomerular glomerular filtration rate. So remember back to when we discussed the function of the kidneys, filtration was one of those three main functions. And the filtration that we are talking about happens in a part of the kidney called the glomeruli. So that's where we get glomerular filtration rate, or GFR for short from. It essentially calculates the amount of blood that is filtered by those glomeruli in the kidneys, and we measure it in milliliters per minute. So the 5 stages of CKD, important to remember here as we stage it, the higher the number, the worse the damage. So stage 5 is more severe than stage 1. In stages 1, 2, and 3, here the kidneys are still functioning, but that GFR, that glomerular filtration rate, is decreasing. So our key nursing interventions here are going to be assess the damage, closely monitor these clients, and most importantly, prevent that further disease progression. Remember that once we do damage, we can't undo it when it comes to chronic kidney disease. So in stages 1 through 3, we want to make sure it's not getting worse to a point where we can't do anything about it. Stages 4 and 5, at this point, we are now towards end stage. The kidneys have now become severely impaired. And here's where we start to consider more invasive options like dialysis or the mechanical filtration of the blood because the kidneys are unable. And we even start to look at the potential for a kidney transplant, whether it's one kidney or both kidneys. Alrighty, so now that we've staged this, what are the causes? How do we end up here? The most common red flag causes for chronic kidney disease are going to be diabetes mellitus and hypertension. So why is this? In diabetes, we see a constant state of glucose, that results from that diabetes mellitus. It can damage the tissues of the body, including the tissues of the kidneys. And then hypertension, so consistently high blood pressure and that high pressure flow can damage many different tissues and vessels of the body, including those blood vessels and the arteries. There's the most important artery to the kidneys are called the renal arteries. And when this is damaged, it limits the blood flow that's able to pass into and through the kidneys, that's able to be filtered by the kidneys, and therefore decreases overall kidney function. So another little tip here overall is that when we see diabetes mellitus, hypertension or high blood pressure, and kidney diseases of any type, these things are really, really closely related. A lot of times when we have an issue with one, it can lead to issues with the other. So I like to think of diabetes mellitus, hypertension, and kidney issues as kind of a little triangle. They're very closely related. Other causes to note include autoimmune diseases such as glomerulonephritis, as well as a genetic disease called polycystic kidney disease. Alrighty, so let's go ahead and move on to clinical features. What are these clients who have CKD? How are they going to present? What are they going to look like when they come into a clinical setting? So one of the key hallmark features of chronic kidney disease is going to be volume overload. The kidneys are not working at full capacity. They're not excreting what they need to be excreting. They're not filtering what they need to be filtering. And this will manifest in a couple of different ways. Things that we see are peripheral edema. So like generalized puffiness, typically the first places that this will manifest is ankles and in the feet, be really puffy and edematic. We'll have pulmonary edema as well. And as nurses, when we auscultate the lungs, we'll hear rales, which can also be called crackles. And it's kind of that popping like crackling sound. I always think of it if you have a bowl of Rice Krispies and you pour some milk on top, it's that popping, crackling like sound. Pleural effusion is another sign of volume overload. This means that fluid has infiltrated that pleural space in the lung, which is going to limit the lung's ability to expand. And what this looks like in a clinical setting is it's going to limit the amount of air a client is able to inhale. They're not going to be able to fully expand that lung. And then, of course, with volume overload, of course, we will see hypertension. There's more volume circulating in a system of the same size, and that's going to increase the pressure. Again, hypertension, diabetes mellitus, and kidney issues are also closely related. Other clinical features include accumulation of waste, and we will see toxins that accumulate in the blood. They can eventually make their way into that interstitial space, come up to the surface of the skin, which can cause dryness or itchiness or pruritus. We can have a buildup of toxins in the blood that can also lead to neurological changes, and this may look like lethargy, insomnia, sleep changes, and peripheral neuropathy, which is that numbness and tingling that we experience in the feet and the hands. All right, a very important manifestation of CKD is going to be changes in the electrolyte balance of the body. So because these kidneys are damaged, they're not able to do their job properly and filter and excrete what they need to be. So this is going to lead to some imbalances of electrolytes in our body. We're going to see high serum potassium, or that hyperkalemia. We'll see high serum phosphorus, and we'll see low serum calcium, or hypocalcemia. Now, to note, last Tuesday we did a live solely on electrolyte imbalances specific to potassium. potassium. So if you're curious, you want to learn more about potassium, that was over both hyper and hypokalemia. But today in CKD, we see hyperkalemia. So that's going to be a great reference if you want to jump back to our YouTube page and check out that past live that we did last Tuesday. Alrighty, moving on, we can also see disruption of the acid-base system with CKD. We'll have toxins and electrolytes, again, accumulating in the blood. I think you may be picking up on the theme here, and that can contribute to an increased acidic environment in the blood, which is a state called metabolic acidosis. Alrighty, we will also see anemia a lot of times in these CKD clients. Remember back at the beginning of this lecture when we talked about the hormone that the kidneys produce. It's one that stimulates the bone marrow to produce those red blood cells. I'm going to challenge you all to go ahead and name it. What was the one I was talking about? Let's challenge you to see if you were paying attention at the very beginning, what is the name of the hormone that the kidneys produce that we talked about at the beginning of this lecture? I'll give you a hint. It's related to the medical term for red blood cell, which is an erythrocyte. So let's see if you guys can get it. I see some answers coming in. Alrighty, so you guys got it, and no worries if you spelled it wrong. It's a tough word to spell, but it is indeed that erythropoietin. Way to go, guys. You always answer these questions so well. So that erythropoietin is, it stimulates the production of those erythrocytes, those red blood cells. And when the kidneys are not functioning properly, they're not going to be producing this at a large enough rate for what the body demands. So when we don't have enough red blood cell production, we have anemia. And then our last manifestation of CKD is going to be bone disease, like that osteoporosis, because remember, we have that low serum calcium, that hypocalcemia. Alrighty, so now that we have finished talking about what this looks like in a clinical setting, what do we do? How do we manage this? So our management here is going to be twofold. We're going to focus on medications and we're going to focus on diet. But something really important to note is that this really only applies to those stages 1, 2, and 3, because here the kidneys are still functioning, we can prevent further damage, and they're going to respond to a lot of our interventions, whereas further down in that end stage renal disease, that kidney function is so damaged that the kidneys won't really respond to a lot of things that we're going to do. So remember, it's diet and medication is our twofold approach here. So medications, what are we going to do pharmacologically to help these clients? So we're going to do things like treat the hypertension associated with that volume overload. And this may look like giving ACE inhibitors or ARBs, which is that angiotensin 2 receptor blockers. This will help decrease that blood pressure, prevent further damage to those really important renal arteries. We'll give ACE inhibitors like our pril family, so think like lisinopril, and our ARBs are those sartans, so think losartan, cosartan, things like that. We're going to help to treat anemia. We're going to give erythropoietin injections. We're going to give iron supplements, help stimulate that bone marrow to produce those red blood cells again. And we are, of course, going to help reduce the edema, diurese some of that volume overload with diuretics. I'm sure you could guess that one. So this is, again, is only in stages 1, 2, and 3 because the kidneys here are still functioning. They're going to be able to respond to those diuretics and excrete or diurese some of that excess fluid. We're going to help to fortify the bones of these clients by giving calcium and vitamin D supplements, and we're going to help to supplement for that low calcium or that hypocalcemia that we also brushed on earlier. We're going to help to decrease that buildup of serum potassium or that hyperkalemia by giving things like sodium zirconium, and decrease that high phosphate, the hyperphosphatemia, by giving things like a calcium acetate, a calcium carbonate. And we really want to address that metabolic acidosis as well. So remember, acidosis is a state of high acid. When we have too much acid, we need to balance it out with more base. So we'll give something called sodium bicarbonate. If you're working in a clinical setting, you may hear this just called bicarb. It's kind of a nickname, but that it means the same thing. Alrighty, so that was medication. Remember, we have a twofold approach here. Our other part is going to be diet when we address these clients. So because we have a tendency to have a buildup of potassium or too much potassium, putting us into a state of hyperkalemia, we're going to be teaching these clients to avoid potassium in their diet. So I'm going to put another question out to the chat, challenge you guys, what are foods that are high in potassium, therefore foods that we would be avoiding in these clients with CKD? So drop your answers in the chat. Let me know what you're thinking. I'm sure you guys are going to get it, but what are our high potassium foods that we're going to be teaching our CKD clients to avoid? Alrighty, and in the meantime, while I'm waiting for you guys to drop your answers in the chat, go ahead and follow us on social media. Whatever your favorite channel is, at UWorld Nursing is our handle, whether you prefer Instagram or TikTok. We are so close to hitting 50,000 followers on TikTok, Instagram, and I believe YouTube, so help us get there. Our goal is to get there by the end of this calendar year, and we're so close. So every follow counts. Help us out if you can. All right, I'm going to check the chat and see what you're thinking. And I see, per usual, lots of correct answers. I see avocado, I see bananas, I see, what else do we have? Spinach, leafy greens. Way to go, you guys are doing so. I see someone say the fast diet. Absolutely. That was something that we talked about actually in last week's lecture. So excited to see that y'all have been tuning into multiple. So we're going to be avoiding things like bananas, like oranges, orange juice, apples, our leafy greens, like our spinach and our kale, anything in high potassium we are going to be avoiding. So remember, we are on a low potassium diet. We are also on a low phosphorus diet because of the proclivity to have those high serum phosphorus. So we're avoiding things like nuts, berries, and again, those green leafy veggies. We're also avoiding sodium. Remember, where sodium goes, water has a tendency to follow. We're not trying to continue to volume overload these clients. So we're avoiding really salty food, which will look like processed foods, popcorn, chips, burgers, fries, a lot of yummy things here, but we're really going to try to avoid those. These clients, because of the fluid volume overload, will a lot of times be on a fluid restriction, which is going to vary by provider order, hospital policy, but we don't want to be having too much fluid that we're orally intaking or through the IV to add on to that already existing volume overload. And interesting to note, these clients will also be on a moderate protein restriction. So this may be a little bit confusing to some of you because protein typically is really good for us, but protein is going to be tough on those kidneys, and we know these kidneys are already struggling with the CKD. We don't want to overload them more. So what we do is we don't completely cut out protein, but we limit our sources to things like lean meats, chicken, fish, turkey, plant-based proteins like beans, and we avoid heavy proteins like red meat, beef, sausage, steak, things like that. So again, a moderate protein restriction, but we're not cutting it out by any means. Alrighty, so let's look at our nursing interventions table. And a reminder that any of these visual resources that we are putting up here for you guys, you are free to screenshot, use them for your own studies. They're really great resources. We make them to help you guys out, so make sure you take advantage of them. So in a clinical setting, what are we doing for these clients? As nurses, what is your day going to look like caring for a client with CKD? Well, you will be closely monitoring their intake and their output. You'll also closely be monitoring their electrolytes, and this may look like frequent lab work. We're really going to be keeping a close eye on that potassium because of the proclivity in these clients to have hyperkalemia or high serum potassium. And remember, we know that serum potassium imbalances can lead to cardiac complications, including dysrhythmias. So that is very serious. We want to make sure we're keeping a close eye on those electrolytes, especially the potassium. We are going to be frequently assessing heart and lung sounds. So with lung sounds, we're going to be auscultating, looking for signs of pulmonary edema, signs of pleural effusion. And with our heart, we of course are going to be monitoring for those dysrhythmias related to the electrolyte imbalance, and this may require a client to be on like a continuous cardiac monitoring, an ECG if we need to. Alrighty, and now those clients that do unfortunately progress to stages 4 and stages 5, that end-stage kidney disease. In the prior slide, we talked about that twofold management, the diet and the medication. Those are really mainly for stages 1 through 3, when the kidneys are still able to respond to these interventions and able to prevent the further progression with diet and medication. However, in stages 4 through 5, kidney function has been severely decreased. Once those kidneys are damaged beyond repair, there's just nothing we can do to go back and restore their original function, so we supplement instead. And this we can supplement through dialysis, which is essentially mechanically doing the work of the kidneys via a dialysis machine, or in some cases we do resort to a kidney transplant, whether that's one or both kidneys. Alrighty, so that is the end of our lecture content. You all did so well. Great job, you guys. Let's go ahead and move on to our questions. Let's test our knowledge, see what we learned here today. So our first question is going to be a diet question. So the nurses taught a client with end-stage kidney disease about recommended dietary modifications. Which of the following menu selections by the client would demonstrate a correct understanding of the teaching? All right, option 1 is oranges and strawberries. Option 2 is a spinach salad. Option 3 would be a grilled chicken sandwich. And lastly, option 4 is tomato soup. This question always makes me hungry, but drop those those answers in the comments below, in the chat below. Let us know what you're thinking. We just covered diet, so hopefully this is really fresh in your brains. I think you're all gonna do so well on this one. A reminder that we have a uworldnursing.com URL. It's easy to remember, easy to visit. This is like a home base for all of our UWorld social efforts. You can plug in your name and your email address to get an email straight to your inbox every single week that tells you what we're going to be covering in that week's live. This URL, uworldnursing.com, also includes a schedule of our next week's content. So you can see the next 3 weeks of what we plan to do, see what you want to brush up on, what you want to see. Again, uworldnursing.com. I see someone ask, what is this live about? I'm interested. I'm glad you're interested. We are covering chronic kidney disease. Alrighty. So I see a lot of answers in the chat. Way to go, you guys. I see almost all option number 3, which is our correct option. Way to go. So proud. So let's look at this question through the lens of what we're trying to avoid in the diets of our CKD clients. So with our CKD clients, remember, we're avoiding phosphorus, potassium, sodium, and we are limiting our protein. We have that moderate protein restriction. So in option 1, oranges and strawberries, we know that oranges are high in potassium. So right off the bat, we can cross this one out. Option 2 is spinach salad. So spinach is a leafy green, which has high levels of both phosphorus as well as potassium. So this one we can cross out kind of on for two different reasons. Option number 3, that grilled chicken sandwich. Remember, we have a moderate protein restriction, but by no means are we cutting out all of our protein. So again, option 3 is our correct option. We're limiting our protein. We're avoiding heavy proteins like that red meat, beef, steak, sausage, and we're swapping it for a chicken or a turkey, a lean fish, maybe a plant-based protein, a bean, but grilled chicken would be a great option to swap for a heavier red meat alternative. And lastly, option 4 is tomato soup. Tomatoes are also rich in potassium, so again, something that we're trying to avoid, so we would not want to be given tomato soup. So again, option 3 is our correct option. Way to go, you guys. Alrighty, let's move on to our final question of the day. So the nurse is caring for assigned clients. The nurse should first assess the client who has option 1, nephrolithiasis and hematuria, option 2, acute kidney injury or AKI and an elevated serum potassium level, option 3, a urinary tract infection or UTI and pyuria, or option 4, chronic kidney disease and a decreased glomerular filtration rate. Alrighty, let us know what you're thinking. Drop those answers in the chat. Alrighty. So this is a more general question. We're kind of asking you to apply the knowledge you've learned today to a more general question. So again, it's a challenge, but I know you all can do it. I see here that you guys can't see the question. Let's give us one more second and we'll try and get it up on the screen. But we'll wait here. Don't worry, we won't move on yet. But again, it was a priority question. It was the nurse is caring for assigned clients. The nurse should first assess the client who has. So important to remember is that in this case, all of these clients are important, but there's going to be one client that's a little more important that we need to do this intervention first because there is an immediate threat to our ABCs, our airway, our breathing, or our circulation. So one client is going to be most important to assess first. Alrighty, and a reminder too, in the meantime, while we're trying to get this question up, no worries, we'll get it up there for you guys. Hang on for just a little bit. But in the meantime, also let us know, drop your answers in the chat for what topics you guys want to see us do. We've had a lot of recommendations for ECG questions, and tomorrow we are hoping we're going to meet that need. We're doing 2 ECG lives, one at 2 p.m. Central Time and one at 3 p.m. Central Time. So make sure you tune in for that. I know when I was in nursing school, I really struggled with ECG concepts and cardiac concepts. So this is a great topic for you guys to do. Alrighty, so drop those in the chat. We've worked in a lot of like pediatric questions, maternal health questions, because we've gotten so many recommendations for that. Mental health as well. We've gotten a lot of recommendations for that, and we have done our best to incorporate that into the schedule so we can help you guys out to the best of our ability. Alrighty, so is the question up? Can everyone see it? Oh, good, good, good. Okay, sorry for that little snafu, but we are back on track, you guys. And the good news is it did not slow you down because I see almost all option number 2, which is indeed our correct option. Way to go. So let's start at looking, why is option number 2 correct before we move into our incorrect options? So remember that we have an acute kidney injury here, so an AKI, and an elevated serum potassium level. So elevated serum potassium level can cause those cardiac complications. From hyperkalemia, we can see things like those peak T waves, prolonged QRS complex. Think back to our ABCs, airway, breathing, circulation. This directly, dysrhythmias affect the C of those ABCs, our circulation. So we'd really want this to be our first priority. Also, just a general test-taking tip for the NCLEX. Whenever you see the word acute, the word new onset, the word change from baseline, this is really going to be a signal that you need to pay extra attention to this option. When we're doing priority questions, when we're doing first assessment questions, the client that has a change from baseline, acute or new onset, it's really going to be kind of a tip or a little trick that you need to pay extra attention to that option because there's a good chance that it's right. And in this case, we have acute kidney injury. So why were the other options incorrect? So let's walk through them. So nephrolithiasis and hematuria. Nephrolithiasis is a type of kidney stone, and hematuria, again, is blood in the urine. This would be an unpleasant but an expected finding of nephrolithiasis. And while this condition can be very painful, it's not immediately compromising our ABCs in this situation, so it's not our priority intervention. Option 3, pyuria, just means pus in the urine. Again, another unpleasant but expected finding of a urinary tract infection or a UTI. This is a sign of a bacterial infection. We would give an antibiotic. We may give some pain medication to this client, but again, not ultimately compromising those ABCs right now. And lastly, chronic kidney disease, very applicable because that's what we've been talking about all day today. We know that staging chronic kidney disease, we do this by the decrease in the glomerular filtration rate, or that GFR. Every stage of CKD is going to involve a decrease in GFR, so this would indeed be an expected finding of CKD and not our immediate cause for concern. So again, option number 2 was our correct option. Way to go, you guys. You did so well today. So I've included a QBank slide, that's going to give you a reference for how to get more questions for all of our UWorld users that have already purchased the product, that have listened to our live today and want a little more practice with the urinary system, with the renal system. Here's there's circles over what you should select. It's adult health and then that urinary renal system option on subjects and system to filter into more renal kidney specific questions. If you're struggling with it or you just want more practice, go ahead and do that. And in closing, thank you all so much for staying tuned today. You did so well. I'm so proud of you. Kidneys and the renal system as a whole can be a pretty complex system. It helps to break it down topic by topic, and I hope we worked through it and cleared some things up for you guys today. A reminder that these lives all live on demand on Facebook and YouTube for your future reference. And a reminder, we go live again at 3 p.m. Central Standard Time tomorrow and Thursday. Tomorrow we're going to be doing an ECG specific question drill at both 2 p.m. Central and 3 p.m. Central Time with Nurse Jackie. And on Thursday, we are welcoming a new nurse, Nurse Brittany, Professor Brittany, to do an oncology question drill. We're super excited about it, and I hope you guys tune in. So thank you so much for joining. Last little thing is we will be taking next week off for the Thanksgiving holidays, but we will see you back the first week of December. Thank you so much for joining, and I hope to see you guys soon.